So today I'm going to discuss this topic, a holistic approach to problems in aging and frailty. So before start this main topic, I just like to discuss few things in the history, mainly some literature in geriatric medicine. Um, so first, this book called The Art of Preserving Old Men's Health, that was published somewhere 300 years ago in early 18th century. This is the first book in English which is considered as uh, the this is purely on the subject of geriatric medicine. So the author in this particular book is trying to explain various tips in healthy life in elderly people. So something like what is called cold plunge bath, that is diving in cold water at old age. These are the tips given at that particular time. So at the same time period, this is another important book came as an essay on health and long life by a famous physician from Scotland called George Cheney. This is also considered as another important work in geriatric medicine. So, where he has given his rules about the good health in elderly medicine, so elderly care. So, like exercise, uh, in addition to better sleep and diet plans. So, this is quite long years ago. Little later, when we come to early 19th century, this book I think it is familiar to us. Most of them aware of this paperwork. This is called an essay on the shaking policy. This is done by Dr. James Parkinson. So Dr. Parkinson is actually he's a physician who lived and practiced in central London, the place called Hoxton Square, where he observed people, some old people who walk along that streets. So, and he observed their peculiar gait or slowness over the period of years, and gradually he observed how these people decline in their general health. He did not have any treatment option to offer, but what he did, he analyzed all these symptoms, and he is written in this paper. That was a nice research paper. Even the at present day, the findings he noted down in this book is considered without much changes because uh, this is so accurate at that point. So this disease was named after him. That is Parkinson disease. Especially this is more common among older people. So then at the same time, there's another one that is called On the Decline of Life in Health and Disease. So that is written by a person called Bernard Van Owen. So this is again considered as the second major 19th century text on diseases of elderly. In this particular book, he tried to attempt to investigate the causes of longevity that is long life, and the best means of attaining healthful old age. So there's a lot of attempt even a few centuries ago. So in this particular book, what he tried to tell, some people even at very old age they have very good health even without having any diseases, or sometimes they have not taken any medicine until their late life. So he believes that it is due to the power of the body and the mind. So these are the important literature part in the history. But when you come to that, so there's another thing that I just want to mention related to this book. In his one of this appendix, he has mentioned about long list of names about the people who lived long years. So this is like somewhere like 1,500 men and women's names who lived up to 100 to 110 years. Even some people, for an example, 47 names are there in the list. They have exceeded the life beyond 120 years. This is in 19th century. So when you get go back to that history about the care of, for elderly, especially these are not our uh, conditions. This is especially in the European and especially United Kingdom. Before the 19th, sorry, before 20th century, the care for the elderly was very limited. Actually, what happened during that industrial revolution, most of the people who migrate to these main cities, and due to their working pattern and the small houses in especially in United Kingdom, they could not maintain extended family. So when their parents got older, so they could not look after. What happened then, most of the time these elderly people who ended up in places like asylum, hospitals, and the workhouses are the places where these poor people who lived there and worked for their food and living. So sometimes they live in these places for years. I have just put an example. This is a famous place on those days that is called Newcastle Dispensary. That is a kind of a hospital for elderly people. So their theme was actually death be inevitable, but humanity will prompt a physician to contribute every aid from medicine in order to alleviate the most painful symptoms. So this is the history about the uh, care of elderly. So when you get that elderly or the older person, who is this? So there's various definitions. So if you go to the WHO definition, so there's no hard and fast. Probably in some it says 60, chronologically it's 60, sometimes it is 65. When it comes to United Nations, for their statistical purposes and all, they take this age limit as 60 as the older person. But in most developed world countries, they consider uh, this aging or the elderly person beyond the 65 years of age. This go along with retirement age, because most of the time this retirement benefit and the social supports uh, started from this cutoff point. But in our country, we are not very sure. So I think it is in the definition it says 60. If our retirement age go up to 63 old, that may be the age limit, or the 65. We don't know, but I think it is generally considered as 60. But the countries like sub-Saharan African countries, even 60 probably too old. So that is all depending on the other circumstances as well. So this is few things about global statistics about aging. So it is mentioned that in 2020, the global population, 1 billion of people who are above age of 60 years, and it is projected to be up to 1.5 billion by 2030. That is somewhere like 1 in 6 people in global population will be more than 60 years, and this will be doubled by 2050 to 2.1. So this is a problem. This is actually this population pyramid from Japan. Japan probably can be considered as the oldest country in terms of aging, because they have reached 30% of population over 60 years. In other European countries and America, that is somewhere 2023. So this chart, the first one in 1930, then 1995 and 1925. That show how this pyramid changes with the time. So they have a huge burden with it's a burden or a challenge because of the large amount of this aging population. So then we need to know what is aging. So it is something complex procedure, actually the complex biological process that is believed to be result from lifelong accumulation of molecular and cellular damage. So it leads to gradual decrease in physical and mental capacity, and obviously they are in a high risk of diseases and ultimately the death. So, and the other thing is this is not linear, because not everyone go in the same process. It is not linear and consistent. A lot of additional factors there. So this is loosely associated with chronological length, and obviously we know that this is a part of life cycle. So because of this reason, so we need to have someone to look after these elderly people, care for elderly or geriatric medicine. So this is a type of practice within internal medicine that focuses on the care of older patients. That is why we like to discuss this topic, because we are the people, probably internal medicine is a place, especially in countries like ours. We look after this patient with elderly. But when we look after this patient, we should have special training in the normal and abdominal physiological and psychological changes associated with aging. And also, we should be able to recognize the importance of maintaining functional independence. So, and the other thing is we should think about what are the preventive intervention for these patients in terms of various complications. So the problems we can associate with aging. So basically, one is a very common problem, that is frailty and multimorbidity. So the other things also associate the same thing, but psychosocial issues, safeguard issues, and a lot of things comes along with this aging process. So the aging process is frequently associated with frailty and multimorbidity. These are the main components which we need. It is go hand in hand with the aging process. So I just want to tell a few more things about frailty. That is one of the main things in today's topic. So frailty, how do we define the age-related phenomena of weakening of homeostasis and lack of resilience to endogenous and exogenous stresses, which increase of adverse outcome, including falls, delirium, and disability. So in other words, this is aging frailties result in vulnerable towards various stresses. So that is how we defined a frailty. So I just want to pay your attention to this diagrams. I know it is difficult to see from the distance. The frailty in elderly. This is a diagram we extracted from an article from Lancet that is in 2013. Here they discuss about what is called epigenetic mechanism. That is the environmental factors and genetic factors. So the combination will result in cumulative molecule and cellular damage that will later ended up in reduced physical reserve of the brain, especially endocrine system, immune system, and many other systems in the body. Along with nutritional factors and physical factors, people more tend to get the frailty. Once this established frailty happens, what happens then? Even the small stressors, they will go into the conditions like falls, delirium, and functional disability. So at that point, most of the people need increased care, hospital admission, and long-term care. So it is obvious that this frailty is more in keeping with resilience and functional status. So at that time, what happened? The small insult result in striking and disproportionate changes in health state. So the people who initial dependent can be independent can quickly become dependent. So the mobile person will become immobile. This is just after minor stresses, and most of the time, this postural stability will lead into falling and falls. So, when it's frail, it is clear that it is not always being old how you look, because old people they have this problem with the muscle mass, that is sarcopenia, and having a long list of medication. This is we can't assess frailty by just looking at this outlook, that is a frailty phenotype. So, what are the frequent clinical presentation of frailty? So, often it is non-specific. So, what happened that extreme fatigue, these are the common complaints, unexplained weight loss and frequent infection like that. But falls is one of the important thing in relation to this frailty, because the balance and gait impairment is a major feature of frailty. Apart from that, we should know about this delirium. It is the rapid onset fluctuation of confusion and impaired awareness. And these people have sometimes they have the good days and bad days. It's like Parkinson's disease. Parkinson's disease, when they are on this dopamine agonist, sometimes they can have the good days where that they walk nicely, but other days they have to be in the wheelchair. That is a classical description. Like that in the frailty, sometimes they have a good days as well as bad days. During bad days, they need increased care. So this is an important article. That is the previous diagram was extracted from the same article. This is done by Dr. Andrew Clegg and the team. It is in 2013 in Lancet. Frailty in elderly people. That is a very comprehensive research paper. They have discussed about the frail brain and frail endocrine system and frail immune system and skeletal system like sarcopenia. This is something that it is interesting if you read. So this one, it is a simple diagram to further explain what is this, how this frailty affect individuals. So if you get this vertical axis, that is a functional ability along with the time. So this dotted line is the border where this patient's independency and the dependency decide. So the green line above, that is somewhere here, that is an elderly person, otherwise fit and healthy. The line down here, that is the elderly person with frailty, they are still independent. What happened with the minor stress like urinary tract infection or maybe respiratory tract infection, they get a dip, small dip. That is, they get a rough days, difficult days with fever, whatever difficulties, but they recover very quickly in very short period of time to go back to their baseline. In a patient, elderly person with frailty, they are very closer to this dependency and the independence margin. What happens? They get a large dip with even a minor stresses, maybe coming with a fall or the delirium or confusion. So the dip is large and the recovery takes such long time, but they normally they don't come to the baseline physical ability. So they will just lie behind. So if you get the repeated the stresses, what will happen ultimately? They will go into dependency, or they can go into there's definitely there's a high risk of morbidity and mortality associated with frailty. So then we should think why screening for frailty. That is basically this helps in predicting the outcome of the patient, and particularly if we have the correct facilities, we can decide where this patient should be placed, and this will help us to involve in the multidisciplinary team approach. So then we should know how do we screen in these patients with priority. So it's very easy because there are a lot of screening tools are there, and it can be done in the general consultation, maybe the bedside, and it is especially it is needed in a patient with multimorbidity. So this one, this chart, probably it's familiar to you. This is called clinical frailty scale. This is a tool they use in NHS UK. That is quite simple. It is actually a marking system from 1 to 9. So 1 is very fit and 9 is terminally ill. Terminally ill person is not very ill by just looking at the patient, because of their other additional conditions like terminal disseminated malignancy or other conditions. Their life expectancy is less than 6 months, so they come under terminal ill. But this number 8 is called what is called that is the very frail, this living with severe frailty. So like that, there's numbering system. If you further elaborate, so this is actually a free the free app you can download. They have given the permission to use for the research purpose and whatever thing. So this is how we see in the uh, our screen. And in this particular person, I have just put the question mark. I just put a yes to this question mark 3. That is, this patient, this is this person completely dependent for personal care? Yes, that means the result is 7. 7 is severely frail. So this is actually a quick guide, an easy way of identifying this what is called this clinical frailty score. The very fit elderly person is actually active and robust. They do regular exercise and engage in social works and all these things. But the other one, number 2, is well. They are good, active, but they are not good as the very fit one. So likewise, it's you can see how it works. But when we apply this into our communities, probably we may need some validation, but still it is useful in our setting. So this number 5 to number 6, you can see that mildly frail, moderate frail, and severely frail. Severely frail person usually severe dementia or completely dependent for their personal care. And number 8, as I earlier mentioned, it is very frail. So this is another screening tool that is called Prisma 7. That is a program on research for integrating services for the maintenance of autonomy. This comes in 7 questionnaire. So again, this one. So if we use, this is also free. But the thing is that we may need some validation when we use for our research studies or daily practice, because the first question, if you see that are you older than 85 years? So in our population, 85 years old may be bit frail than what we expect. So certain adjustment may be needed in our setting. So with this thing, there are some very comprehensive frailty index scales as well. This is actually in the apps form, so we don't need to remember these things. There's 36 components. In this particular patient, I have put some red markings here. These are the condition patient is having: atrial fibrillation, diabetes, falls, and so on. So 9 conditions. When it comes 9 out of 36, the frailty index is 0.25. So there's a cutoff value, so it is easy to get some idea about the patient's frailty level. So when we discuss about this frailty tool, so I just uh, got this research work done by this Sri Lankan team, actually one of our colleagues in Kotalal Defense Academy. They have seen the prevalence of frailty in their OPD presentation, the elderly persons. So they have used this Prisma 7 with some validation. So it says that 75 to 64, 84, yeah, that is the age range. So they have about 67% with evidence of frailty. Like that, they have analyzed these things. So I just got the verbal consent to put this slide here today. And these are the common presentation for their VPOPD clinics. Elderly person, basically they have large number of patient comes with musculoskeletal pain, leg ulcers, and rheumatological problems. Sometimes infections like cellulitis, urinary tract infections. They may ended up in a hospital admission in certain conditions. There's a long list of things. But interestingly, they have less number of stroke. That is probably due to these stroke patients are divert to different pathway. That is the reason. Because otherwise, we know that strokes are common among elderly. So we discuss a bit more about priority. I just want to tell a few things about what is called this multi-morbidity. So this elderly person, these two are the major problems which is commonly associated. So multi-morbidity is the coexistence of two or more long-term conditions. So that can be a defined physical and mental conditions like diabetes mellitus or hypertension or schizophrenia. So if not, it could be something like ongoing problems like learning difficulty and the symptom complexes like frailty and chronic pains. Even the hearing and the vision loss comes under multimorbidity. So substance use also part of that. This is two or more is multimorbidity. If the long-term conditions, if it is more than four, that is called complex multimorbidity. So when you have this kind of multimorbidity, actually, if you need to have a better care, this gold standard approach is called this comprehensive geriatric assessment, that is called CGA. So this is an interdisciplinary diagnostic procedure which determine the medical, psychological, functional abilities of someone frail or old. So this is actually need to plan the long-term care. So but it is not easy because we need a lot of resources. It is hard in our setting, really speaking. So these are the things which look in this what is called this comprehensive geriatric assessment, that is called 5 M's in geriatrics. That is mind, mobility, medication, multi-complexity, what matters most. So if I just elaborate this thing, so this is basically the holistic patient-centered way, 5 M's in geriatrics. So mind is basically we need to look into the thing called dementia, depression, and delirium. And mobility, this is something that we probably underuse our facilities because mobility need to be assessed in the elderly people. It is the largely assessed by the physiotherapists in the other health settings. But in our setting, probably we refer very unwell patient, ICU patient sometimes, if not our stroke patient only. But most of these elderly patient, they need mobility assessment. Then the medication, we know that the condition called, I'm not going to details of this polypharmacy. In elderly, this is one of the biggest problem. The polypharmacy can be appropriate polypharmacy, that is the evidence-based medicine in appropriate manner, but most of the time it is inappropriate polypharmacy because elderly patients may be having drugs which is not really needed. But even the evidence-based medicine, if they do it take in an inappropriate way, that can cause a lot of problems. Then we get this what is called the multi-complexity. It is basically the medical complexity and the social complexity. So we never go into this level in our elderly patient when they come to hospital, because they have a lot of problems in relation to their home environment, safeguarding issues, as well as the social and the many other factors. These things need to be elaborated using collateral history, and especially by this has to be done by occupational therapists. In a hospital like ours, I mean the Peradeniya or Candy, we have this occupational therapy support as well as physiotherapists. So I think if we have comprehensive care, we can get their involvement much much better than what we do at present moment. And the last question that is also very important, because what matters, sorry, so that is this what matters most to you. That question is always important. Sometimes this elder person, they may be having some problems which we never think. Sometimes even they are waiting a phone call from their sons, daughters, or grandchildren. That may be the main worry of this patient. So sometimes that we need to get counselors, as well as at one level there may be psychiatric involvement as well. These are the main things. That this is what I try to explain. High MS in geriatrics. So I also had an opportunity to involve in some works with my supervisor when I was doing some training in this elderly medicine. But this is basically uh, in that community-based level. There we discuss about few approaches in community MDT meetings and medical management in nursing homes and domiciliary visits. But this kind of practice may not be applicable to our setting, because in the where the study was done, that is in Birmingham, they have about that short area, the small area, they have about 65 nursing homes. But that is their culture and the way, because uh, it is because they can't have the extended families in their houses, because in UK I don't think they have big houses. But our setting is different. But we have a lot of family support, the extended families. But this the safeguard issues and vulnerabilities and the other the social issues we don't normally see in our setting, or we don't go into the depth. So with this background information, I think we discussed few things like how do we assess frailty and multimorbidity and other main problems which can arise in elderly. I just put this case scenario to discuss few things in relation to what we discussed. This is 82-year-old lady living with some memory impairment. She was found on the floor by her daughter, brought to the ATU by an ambulance. So in background history, she normally lives alone in the daytime because others go out for the work. Then she normally use a stick to walk inside the house. She doesn't come out without others' support. She's hard of hearing, and she often gets constipation as one of her problems. So in her background history, she has ischemic heart disease, hypertension for many years, and it was recently diagnosed in early stage of Parkinson's disease. And her medications, she's on statin, and aspirin, amlodipine, furosemide, and syndopa. So on arrival at ANE setting, her blood pressure, that is obvious, she had blind blood pressure 102 upon 70 and standing 80 by 60. She was dehydrated and she was disoriented in time and place. Her urine dipstick shows positive for nitrates. So this kind of patient, there may be long list of problems, and I just list out the possible causes and the problems here. Collapse may be secondary to posture. It is secondary to postural hypertension, obvious, but there may be associated urinary sepsis, and she now has early signs of delirium and ongoing memory problem. And there may be possibility of antihypertensive overdose, because she came with a postural drop, because she's having some memory impairment. She may be getting the repeated doses without her knowledge. Unless we go into details, it is difficult to see. and her problem, she has a problem with her mobility, and we don't know how good the house environment, whether she has stairs and whether she has bathrooms close by, and she lives alone at home, and there may be some safeguarding issues as well. So the question is this patient frail? So basically, if you put this clinical frailty score, we should not assess the frailty score at that acute stage. At least this patient score should be assessed 2 weeks prior to this acute illness, because that is the baseline. Probably it is somewhere around 5 or 6. That 5 is mildly frail, that the patient has mild dementia, need help with sopping or the outside birth. Or moderate frail means that they need help for the bathing and cooking and all these things. So then we need to see whether this patient is having some evidence of multimorbidity. Of course, yes, because this patient has at least 3 long-term conditions, like as we discussed, ischemic heart disease and hypertension, and recently diagnosed Parkinson's disease. And she is obviously frail, and she has hearing loss in her previous history. So this kind of patient, actually we need to assess whether she is having a state of delirium. Probably we do not do in a I would not say it's proper manner, but we don't have a systematic manner to assess the delirium and the cognitive impairment when they arrive. So this is called 480. 480, that is the scoring system to assess delirium and cognitive impairment. So these are the components here. Alertness, whether this patient normal or mildly sleepy, or whether it's clearly abnormal. Like that. The second part is abbreviated mental score. Age, whether patient can remember age, date of birth, place, current year. So I will not go into details. Attention, acute changes, or fluctuating cause. So if score is more than 4, that means patient has delirium plus or minus cognitive impairment. 1 to 3 means possible cognitive impairment. If both are normal, so patient may not is less likely to having these two components. So these are the way they try to catch these patients, because when we practice in this other settings like NHS, we have to screen for these patients. So every patient who is above 65 years, they should go through a checklist list like this. This is delirium checklist where I worked earlier. So we know that our particular patient, ideally this patient need this kind of a comprehensive assessment. In our setting with our workload, probably we are far behind what is expected from us. So whether we can assess their mind, like the state of delirium, and whether dementia and mobility, the physiotherapy assessment, medication, probably medication review done by the most of the time during admission, but multi-complexity like social issues and house environment and adjustment, this it is not practical for us to offer at this current situation. And but still we can ask from the patient what matters most. So sometimes patient will come out with certain things which can be correctable. So these are the things that I just mentioned about this 5Ms in particular in relation to this particular patient. So we are actually reaching the last part of the lecture. So I'm not going to details for this what is called the last days of life. Elderly, that is a part, because this is as part of life cycle. So we become frail, and sometimes we get a lot of comorbidities, multimorbidity, or the complex multimorbidities at one point. We need to think about what can we offer for the patient. This is the last days of life, or the palliative care. This is called best supportive care pathway. Earlier it came as what is called Liverpool care pathway in UK, but the name was changed to what is called supportive care pathways later on. But I don't think that we have organized way of assessing this what is called the last days of life. So nowadays they have changed that previous pathways, because they had a lot of challenges during this COVID pandemic, because applying this normal supportive care pathway was not that simple at that point. So what happened that this is the place, this is the form that was earlier tried there what is called do not attempt cardiopulmonary resuscitation DNR CPR form that was practiced earlier, but later on they changed it, the wording and the things slightly because there are some difficult areas when we face challenges like pandemics. So then what is called now they practice in certain all this trust in different ways. This is called the respect form, the recommended summary plan for emergency care and treatment. This is actually acute setting. If we get an older patient, even a young patient with multiple comorbidities, we have to fill this form within the first 24 hours or on arrival to A&E by the medical registrar or the consultant. If the specialty doctor fill this one, it should be covered by the consultant within 24 hours. That is the way. That doesn't mean the patient is in the dying process, but we have to discuss with the patient. In this new form, they have given the power of attorney to the next of kin. Earlier, it was not there. So these are things. This is in the acute setting. But even in the community setting, they have community-based DNR CPR forms. So this question is always, or most of the time, discussed with the patient. They accept it. Sometimes they agree. Most of the time, agree. Sometimes there are some disagreement. But this is for the betterment of the patient. So in our setting, when the patient, elderly person, go into the decline in the general condition, so there's a lot of confusions because the family will expect whatever you have to do like that. So whether we are going to intubate, so if you have this clear plan what is the care that we have to give, we should give at that point, it is very easy. But these kind of patients, they will not get any uncomfortable feeling because there's a specific pathways to follow that we can make them comfortable. Their pain will be managed, their secretion will be managed. This is actually acute setting, but in the long-term setting, in the community, they have a separate path. So these are things which may not be easy to apply applicable to in our setting. But without discussing about this end of life care path, it is probably incomplete to discuss the holistic approach to elderly and frailty. So this is actually I just put this slide. This is the place I got this inspiration regarding this management of the elderly people. This is the place in Birmingham where this acute ward for elderly, where I had some training at that particular period. And I just want to put this place. This is actually called Rowley Regis Hospital. It is in a nice countryside. It is a rehabilitation and intermediate care wards. When the patient recover from that acute stage, they have the system like this. They can move this patient to intermediate wards because they are not fit enough to go back to their own house. They need a lot of care until their care package is put on. They have to be in the intermediate. Otherwise, they will be moved to their own house. If they are not safe enough to go into their own house, they will be moved to either nursing home or uh, the care places like full package or half package. There's various ways because that is quite a comprehensive way of doing that. I used to go to this place probably once a week, like, because they have their own GPs to look after minor problems. If they get acute deterioration, they will transfer this patient directly to our acute wards. In between, the other problems will be looked after by the either physician or the specialist doctor from the main hospital, like once a week basis. But during this stay, they have a lot of physiotherapy, occupational therapy, social service supports. So this is the system that they have adapted. Probably we may not be able to go up to this level, but with our available resources, we can give better care if we know a little bit about what is exactly happening in this aging process and frailty. So the references, basically, I got these references for preparing this lecture, and I just want to thank my supervising consultant in Birmingham, where I learned certain things in somewhere in 2016. Dr. Mutao, he's a specialist in geriatric medicine as well as in Parkinson's disease. Right. Thank you very much for your patience, listening, and presence here.